Hello everyone, my name is Jeff Suggett and I'm the Chief Executive Officer of the Canadian Digestive Health Foundation. Thank you for joining us this evening. Welcome to the second part of our medical cannabis webinar series, Laying Out the Evidence. The webinar tonight has been made possible through an unrestricted educational grant from Spectrum Therapeutics. For those of you who are unfamiliar with CDHF, we are the charitable foundation of the Canadian Association of Gastroenterology, which means we are directly connected with Canada's leading digestive health experts, physicians, scientists, and other healthcare professionals. So you can trust us to provide you with practical science-based information that is up-to-date and unbiased. Just a note, this is the second webinar in our three-part medical cannabis webinar series. So if you haven't already, check out the first in the series, which is posted on cdhf.ca, and make sure to register for the third and final episode in the series, where we will be hearing from a few patients and their experiences with using medical cannabis. That final webinar will be held on June the 13th. Our presenter this evening is Dr. Christopher Schneider. Dr. Schneider is an assistant professor of gastroenterology at the University of Manitoba. His practice involves the treatment of patients with irritable bowel syndrome, Crohn's, ulcerative colitis, and liver disease. And he has been one of the strongest voices advocating for an evidence-based approach to medical cannabis. Just a few housekeeping notes before we get started. This is a live presentation. During it, if any questions come to mind, please enter them into the question box in the bottom right-hand side of the screen. Questions will be addressed at the end of the presentation. If you do not see the question box, click on the Help button for technical support. So without further ado, I'd like to welcome Dr. Schneider.
Hello, welcome everyone. So this is, as Jeff said, this is the second webinar that we're doing as part of the medicinal cannabis series. And so in this one, the first one we looked at the difference between medical and recreational cannabis and try to give the audience tools to decide which one was the best route for them. In this one, we're going to talk about the evidence in gastroenterology for medical cannabis, as well as talk about some of the studies that showed some of the risks and adverse events with using cannabis. So it's a very, very large topic. There's over 29,000 studies in many different areas, including gastroenterology, that have studied cannabis. So it's a very, very highly researched area. So when people say there's no studies, there's many, many studies. The difference is many of these studies are smaller studies, and and I think it's important that the first step is we take a look at what are the different types of studies, so that'll give us some tools to decide of how what kind of quality and what kind of conclusions we can take from these different studies. So the evidence in medicine has been evolving over time. So I just sort of first want to ask, what do we mean by evidence? And so when people say where's the evidence, there is evidence, there's strong evidence, there's no evidence. What does that actually mean? Can one study really be superior to the other, and how can these studies be applied to someone's specific situation? So before the 1970s, evidence-based medicine didn't really exist. It was more of the art of medicine, where there was experts in certain fields, and people really relied on their opinions. There was a large value put on experience, and there's sort of there's certain authoritative voices in each area. So that there was a very highly acclaimed professor at a hospital, they would say Professor K said this is the way we should do it, and this is the way we do it. And the residents and students would learn that way and adopt that way and apply those teachings from their professors. And there wasn't really a look back at the, are the studies to support what, for example, Professor K said about how to treat diabetes. And so medicine was done very differently across even a same city, definitely across country, and very different between different countries. And that's where there's a large importance that communication, and the conferences, so people could share their different opinions and their expertise. Then in the in the 1970s, so by 1973, there was a movement towards applying studies, so studies of probability and percentages and likelihood, odds ratios, kind of the stuff that we talk about when people are doing mathematical formulas when they're trying to calculate what the likelihood of when playing cards of a certain card coming up, or a likelihood of a certain event happening in the weather. And so this sort of started to get applied into medicine. And the two real leaders of it was Robert and Susan Fletcher. They're professors at McGill University. They were Americans that got jobs at McGill, and they really focused on epidemiology and so the different traits that different populations would have, and how you use that to apply that to the clinical situation in decision making. And they published a book in 1982 called Clinical Epidemiology: The Essentials. Then that was taken in the 1990s by Dr. Gordon Guyatt at McMaster University, and he's really the person that coined the term evidence-based medicine. And he was the residency program director of internal medicine at McMaster University, and throughout the 90s he published multiple articles in the DMAJ, which is the Canadian Medical Association Journal, as well as JAMA, which is the Journal of the American Medical Association. And he was advocating for applying studies to the clinical situation, as well as gave, it wasn't just sort of a reader's guide. He would say this is a user's guide. So he really wanted to give physicians the tools to apply it, as well as to critically appraise the articles to see if these articles were even worthy of being considered to be applied, and then if they were worthy, could they actually be applied? Do they fit into that clinical situation? So evidence-based medicine, which went around the world, really was a Canadian invention. This is something that I think we should be quite proud of in Canada. It's McGill and McMaster University that were the real pioneers, and went around the world. And when I did some of my training in Australia, they were talking about evidence-based medicine, and that came from us here in Canada. So an industry was born, and in McMaster University created the Cochrane Review, or the Cochrane Collaboration, where they would do these things called meta-analysis, where they take the metadata from multiple studies and put them together. Multiple search engines that were studied, which included all the different studies, and you could use keywords to find them, such as Medline, PubMed, Embase, all came together. Different online textbooks that would be updated on a daily basis, called like one, for example, Up to Date was the big one. And then even Google got into it with Google Scholar, which is a totally separate search engine. You could find it in your Google browser by typing in Google Scholar. It would take you to a totally separate search engine, and this is one where there's only studies there. And so it became a very, very big industry and used around the world. So I just want to talk sort of about the different hierarchy of evidence. So when we're talking about different studies, definitely not every study is created the same. And there's this, so one thing that we talked about a lot when I was going through medical school in Ottawa was, what are the different studies? When can these studies be applied? And what kind of strengths do these studies provide us in creating, making conclusions and making clinical decisions on our patients? So the lowest level is at the bottom of the pyramid, and they basically say, this is editorials or expert opinions. So the pre-1970s, they put the least amount of value on this. So someone who, even though they might have been an expert their whole life, and they have a huge amount of experience, their opinion, their experience could be, sort of biased by certain experience, things that they saw, and it's although I feel that these people have very, very valuable opinions, as far as the evidence-based medicine algorithm, it's put the lowest on the pyramid. The next one is meta-analytic studies, or and many of those are animal studies, and we'll go through some of those. And so they're basically physiology studies. So they say, well, if I gave, let's say, an immune cell and I exposed it to cannabis, like a THC, let's say the cannabinoid THC, and that cell calmed down. Now that would be, and the authors of that made a conclusion saying, well, that all shows that cannabis can reduce white blood cell activation, which means it can reduce inflammation in the body. And so that's, so that you can see that just by judging just on the cell, is that really the truth? Is that just maybe the reaction of one cell, but the whole system acts differently? And so that's why those are lower on the pyramid, as well as animal studies. It is very informative what happens within a mouse or a rat, but we do have different physiologies in a mouse or a rat. So just because it happens in a mouse doesn't mean it's necessarily going to happen in a human. Next one is case reports or case series. And those are basically, it's an interesting case that you have, you publish it, or you publish a few different cases, and this is something that was seen. So, for example, cannabis decreased seizures in newborns experiencing refractory seizures. It's a small sample size. It's not a big group, but it is more important than an animal study or an evidence or an expert opinion. Higher up on the list is cross-sectional studies. And so those are really just, they basically take a group of population and a certain characteristic at one point in time. And so it gives you a good idea of what's happening with that group at that one point in time. But to draw direct conclusions from it, a little bit harder. So, for example, an example of a cross-sectional study would be there is people with Crohn's disease. There is 50% of people with Crohn's disease use cannabis, and they report that it reduces their symptoms. So to say that, if the author said that means cannabis reduces, that cannabis is an excellent treatment for Crohn's disease, it would be hard to say, to make that strong conclusion about it, but you would be able to say that cannabis can reduce symptoms in people with Crohn's disease based on this data. The next one is case control studies, and those are studies where they look at a group of people, and it's a retrospective study. So all the data is there. It's usually a chart review that's done through medical records, and it looks at a certain aspect, like sort of two associated aspects. There is a link between them. So, for example, if you looked at a population, you looked at how many people in that population have Crohn's disease, and out of those people who have Crohn's disease versus those who don't have Crohn's disease, how many of them were using cannabis? And if you saw that people who used cannabis had less Crohn's disease, it would maybe, for even that hypothetical study, would say that perhaps cannabis protects against Crohn's disease. It's retrospective, so it's not as strong as a prospective study. However, it's an easier study to do because it's just a chart review in medical records. The next one up from that is a cohort study. So that's where you follow a group of people prospectively for a certain group of characteristics and see how they're doing. So the cohort study is a hypothetical study. You take a bunch of cannabis users and non-cannabis users, and you can see which ones go on to develop Crohn's disease or not. And so it's a little bit stronger. It's a prospective study, and you're gathering data as you go on. The weakness of that one is obviously it's more expensive, harder to do, and it could span many, many years before your study is finished. The next ones are the randomized control trials. And those are ones that, and there's different degrees of how good a randomized control trial is based on how many people are in it, whether if the scientist or the clinician are blinded, and the patient's blinded, which are in situations where they're both blind, that's considered a double-blind trial, and with many institutions are put into it. And so this is basically, a randomized control trial would be there's a group that gets cannabis, another group that gets a cannabis-looking substance that has no cannabinoids in it, and you see, and these are people with Crohn's disease, and you see how well they respond to the cannabis. And if it's double-blinded and multi-center, and with a large population, it could be a very powerful study to say whether this works or not, and that's why it's really at the highest end of the pyramid. So the other way that you'll see when you guys are doing Google, let's say, for example, Google Scholar Review, most of the things that you'll catch will be abstract. And the abstract is basically just a summary of the study. However, the study is either the full length study. Typically you have to have you have to be paying and have access, through PubMed or Medline, or in Google Scholar, you can often pay and get the full text. So a lot of people will just read the abstract, but there's a lot, a lot of times the details are very, very important. So if you really, when we're assessing studies and deciding as doctors if we want to apply to our patients, it's really important that we read the entire study and to see if the conclusions in the abstract are really warranted. So, and there's a whole sort of bunch of questions that I kind of created for you guys, and these are questions that I go through when critically appraising studies. So there's, you want to know if it comes from a peer-reviewed journal. So some journals are stronger than others. For example, the New England Journal of Medicine, very, very difficult journal to get your study into. So, if it comes from New England Journal of Medicine, you're looking at a study that was published there, it carries a lot more weight than one from, for example, the World Journal of Gastroenterology, which, even though it says world, is very more basic. It has less of a rigorous process to accept studies or not. Did the authors present a hypothesis? So did they make a statement that they were testing for the part, or did they at the start, or did they just collect data and try to make conclusions from it? So it's a lot stronger if they sort of put themselves out there and really ask a very clearly defined question at the start. Other things are, is there inclusion and exclusion criteria? Did they just accept everyone, or did they eliminate some confounding factors, especially in terms of the patient? Is there been steps taken to limit bias? Do they describe the groups and the people they studied very well? What statistical methods they use? If they're drawing conclusions, is there a statistical significance? And there's many different formulations that you can use that can get quite technical, but are important to see. One often important thing is p-value. And then did the authors acknowledge that the limitations? Every study has limitations. And are there any conflicts of interest? So with this sponsored by a pharmaceutical company, you start, you wonder where some of the data excluded, where some of the criteria changed to get sort of a more favorable conclusion for the medication they were studying, especially if there's a sponsor behind it. So at the end of the day, though, after you've looked at all these studies, the biggest question you have to ask, does this apply to my patient? So there's many different methods that you can use, but that's the most difficult part. After you have a study, does the study actually go towards, and can actually, is appropriate to apply it to this particular clinical scenario? And that's some of the things that sometimes I think doctors sometimes will try to apply a study and it's not appropriate to apply it in those situations. So some of the criticisms of this new approach to medicine, a criticism to evidence-based medicine, is some people call it cookbook medicine. As we all know, like, the best chefs in the world, is more of an art to them. They can create much better recipes and dishes when they're just fueled by passion and their expertise rather than following like a cookbook. The other thing is these randomized control trials, they're under very, very well-controlled situation. They select very, usually urban and very motivated patient population, so that ivory tower conditions people talk about. And they often exclude patients that have other diseases, so it doesn't confound the conclusions. However, in real life, many patients have multiple diseases going on at the same time. It doesn't take into account the patient's preference, their access to medications, or the socioeconomic status. So even if a study says it's right for the person, is that really what the patient wants? Is that medication even available to us here in Canada? And can the person afford it? And there's a danger that in evidence-based medicine that governments or insurance companies will start to use these as the goal, as the only thing that should be used in clinical decision-making. Patient's preference doesn't matter. The art of medicine doesn't matter. And they'll create algorithms that need to be followed, protocols, and it becomes, patients get placed into these algorithms, and they have to follow that. It's the only thing that's going to get paid for, the only thing that's going to be delivered, and that might not be the right thing for the patient. So there's definitely some weaknesses to this approach. So looking at the evidence, so sticking with the evidence-based medicine paradigm, we'll look at the evidence in terms of medicinal cannabis, and I'll talk about some other areas where there's evidence, and then we'll focus on gastroenterology. So this is a table here that talks about in terms of the current state of the strength of evidence. So I talked about 29,000 studies where there's considered substantial evidence, so a large amount of high quality trials, and where there's limited evidence. So the areas where there's, they would call it slam dunk evidence is the treatment of neuropathic pain. So for pain management, excellent evidence for both capsules, oils, and dried leaf treatment, synthetic and natural cannabis. Chemotherapy-induced nausea and vomiting, excellent evidence in that area, and for reducing spasms in people with, especially people with multiple sclerosis. You see in the category of limited evidence, anxiety disorders, PTSD, social anxiety disorder, generalized anxiety disorder. Those areas, there's actually limited evidence, actually conflicting evidence. Some evidence to show that it helps people and makes them better. Other evidence to show it makes people worse with those conditions. Drug-resistant seizures. So there's every documentary you see on medicinal cannabis is advocating for it. They always start off with children with seizures and the Dravet syndrome, and they show that this really miraculous response to treatment. But that's unfortunately that's not the case for every child with the treatment-resistant seizures, and there's a lot of cases where cannabis unfortunately does not work for those patients, and unfortunately nothing works for them. There's certain cancers, glioma. There's some evidence, IBS we can see in our area, as well as inflammatory bowel disease. Is still considered in the limited evidence category. So going to these are some of the pivotal trials that support cannabis use for chemotherapy-induced nausea and vomiting. And some people, it was studied originally with chemotherapy-induced nausea and vomiting, and it shows equivalency to medications such as ondansetron, which is sort of the go-to medication for controlling vomiting after chemotherapy. Now, there has been less studies for regular, non-chemotherapy-induced nausea and vomiting. So people who are suffering with nausea and vomiting who haven't taken chemotherapy. However, in my practice, I find the cannabis works very well, and you can extrapolate a lot of these findings from these studies and apply it to nausea and vomiting that's not associated with chemotherapy. Neuropathic pain, some of the very large trials here in terms of supporting cannabis use in neuropathic pain. And the other sort of people talk about, especially the pain management specialists, is that cannabis doesn't only help in controlling the neuropathic pain, but also helps treat many of these other conditions that people suffering with chronic neuropathic pain suffer with. And so the cannabis does help with appetite, with sleep, some extent anxiety and depression. And so these are some of the other sort of comorbid facts, or comorbid conditions that the pain specialists feel how the cannabis helps in treating these patients. Another area which wasn't on that original list, but is HIV/AIDS associated weight loss. Very, very good evidence for this as well, and those are some of the pivotal trials. These are the trials for multiple sclerosis and spasticity. Also excellent evidence. So going to gastroenterology, there's so we'll start off with irritable bowel. So the most common referral to gastroenterologists that comprise a large amount of our practice. For me, it was about 70% of my practice was IBS, and very, very difficult to treat condition. There's a lot of, unfortunately, a lot of physicians who don't have much interest in treating IBS, and patients are often left, feeling like they're going crazy and things that there's no treatment for them and they can't escape their symptoms. Some of fortunately, there's lots of research occurring in IBS at this time, and some of the underlying causes are being further explored. The brain-gut axis, that's very much related to anxiety and stress, is being very much explored. That's and it's extremely interesting research that show that what's going on inside our gut largely affects how we're feeling inside our nervous system, even our central nervous system, our brain, and there's even the bacteria inside our digestive tract have somewhat even they release signals that even have some control even over the function of our brain and what we do, and vice versa. So that the brain and what's going on in our nervous system largely affects our digestive tract. The microbiome is a very, very hot topic. We have 100 trillion bacteria that live in our digestive tract, only 10 trillion cells in our body. That means the bacterial number is more than 10 to 1. And so there's the type of bacteria, the number of bacteria, as well as the location of bacteria. So Mark Pimentel, who's a Canadian, trained in Manitoba and now down at Cedars-Sinai Hospital in California, put together some very convincing evidence that to show some links between irritable bowel syndrome and SIBO, small intestinal bacterial overgrowth, as well as excellent research, some of it coming out of Australia, showing the role of FODMAPs, and so the food that we're eating and even some potential food allergies that are undiagnosed and are causing IBS-like symptoms. So looking at the role of cannabis in IBS, we're talking about the hierarchy of evidence. There is, so right now it's stats, it's only mechanical type studies that are showing, so physiology studies to suggest the potential role for cannabis in IBS. As far as large clinical studies, there's none. There are case reports, but nothing to draw significant conclusions to support the use of cannabis at the time. So we'll go through a few of these studies. I kind of summarize them. So this is a study out of Mayo Clinic, and so what they did is they took 30 healthy volunteers. So these are people without IBS, and they gave them dronabinol, which is a synthetic cannabinoid, versus placebo. And they wanted to see how well the patients accepted food. So they did this thing called a satiation test with Ensure, which is a meal supplement. And they looked at the maximum tolerated volume and looked at what their volume was 30 minutes after. And then what they did is they did a scintigraphic transit where they put a tracer on an egg, and they looked at the difference when someone took dronabinol versus placebo in the fasting state as well as in the postprandial, which means the post-meal state. And then on day 2, they looked at the clonic transit when people were taking dronabinol versus placebo, and they repeated the satiation test. And what they found is that the people who were taking dronabinol, the synthetic cannabinoid, had increasing fasting volume, as well as the gastric emptying was slower in dronabinol, and it was significantly pronounced in females more than males. And so with that sort of, people with IBS often suffer from a large amount of bloating and nausea, especially after eating. So if their stomach is able to take on more food and can accommodate more, that sort of supports the physiology that cannabis could be useful in people with IBS. Also slowing down, so maybe with IBS, especially people with IBS-D, have a rapid transit. The food comes out of them really fast. They have to run to the bathroom an hour after eating. So if it slows the digestive tract down, this could be helpful in people with IBS-D. So it's another study here. This was done by the Harvard group, and it was published in the American Journal of Physiology of the Gastrointestinal Tract. They took 52 volunteers, so this is, again, people without IBS. They assigned them and it was double-blinded, so both the patient and the clinician didn't know who was getting the treatment and who was just getting the placebo. They used a slightly higher dose of dronabinol. So they gave them the dronabinol, they gave them the placebo, and then what they did is they looked at they did this thing called the barostat. And so what they looked at is the colon, so not the stomach this time, and they looked at how well the compliance, the tone, and how much they could distend the colon before and after a meal on people who took the synthetic cannabinoid versus the people that took the placebo. And what they noticed with the people that taking the cannabinoid, that there was increased colonic compliance, so that just like with the other study with the stomach, that it was more flexible and more accommodating, the colon in this case, more accommodating. There was decreased colonic tone, so it means that things slowed down. And there's inhibition of postprandial contractions. So these contractions we typically get an hour after eating, there was much less of those contractions in the people in the cannabis arm. This is a study, this is a Mayo Clinic study here again, and so this is where they took, so this is a sort of a slightly more pertinent, well, definitely more pertinent study where they took, so rather than healthy volunteers, they took people with IBS, and they divided them into people with constipation versus people with diarrhea versus people who had an alternating, we call this IBS-M, like IBS mixed, between where they had an intermittent between diarrhea and constipation. And they were randomly assigned either two different doses of dronabinol, the synthetic cannabinoid, or placebo. And they looked at, again, how the colon was doing, because that's where most of the disease occurs in IBS. And what they found is that there was decreased during the fasting phase. There was decreased movements of the colon, increased colonic compliance, and the greatest effects for patients, like the changes that they saw with the dronabinol in this physiologic study, is that it was greatest with people with diarrhea and alternating symptoms between diarrhea and constipation, which kind of makes sense. So some of these physiologic studies, that cannabis definitely slows down the digestive tract. It increases compliance, so that people potentially feel as cramping, has much cramping and bloating. And so slowing things down makes sense for somebody with diarrhea. However, somebody with IBS-C, like the constipation predominance, it can actually potentially make them worse because it would slow things down and worsen the constipation. Now, these are physiologic studies, so these, it's not a clinical study where there's an intervention. Symptoms were greatly assessed as well as physiology. So these are weaker studies than there's lower on the pyramid than they could be, than if there was a randomized double-blind trial. So now looking at inflammatory bowel disease, IBD. So that's divided into Crohn's and ulcerative colitis. That's a very large portion of a gastroenterologist's work. This is, gives many of the same symptoms as IBS. However, the difference with this is it can lead to very life-threatening conditions where it leads to major bleeding, leading to inflammation through the colon as well as inflammation throughout the body. So there's, starting off with this study, this is an animal study, but I thought I'd present it to you because it's pretty interesting. So they're looking at the endocannabinoid system. I'm sure you've heard lots about the endocannabinoid system, but we have natural, naturally produced cannabis inside our body. So this study was looking at sort of what the role is of the cannabis receptors inside our digestive tract. And the cannabis receptors inside our digestive tract are CD1. There's the other receptors that people talk about are CD2, and they're mostly found on the immune, like the white blood cells. So they took this thing called DNDS, which is dinetyl benzoate sulfate, and it's a known sort of something that's used in many clinical trials, and it's something that's known to cause inflammation of the colon, so causing colitis. And they gave it to two groups of mice. One group of mice where they had the CD1 receptor, and another group of mice where there was a genetic change in those mice, like an intentional genetic change where they were CD1 deficient. The patients, like the wild type mice, the ones that didn't have any change in their genetics and they had the CD1 receptor, had less inflammation than the ones who had the knockout. when they gave a cannabinoid receptor, which is the chemical that they use, which is very it mimics cannabis, is HU210. It resulted in protection when the mice were given the DNDS pro-inflammatory agent. And they also noticed that after the mice were given DNDS, there was an upregulation of the CB1 receptor in their digestive tract of these mice, showing that there is a role of CB1 receptor in protecting against inflammation in mice. There's a study done in Toronto after that showed just sort of wanted to evaluate what was the use of cannabis in the inflammatory bowel disease population. So they divided into they found 100. They surveyed 100 ulcerative colitis patients and 191 Crohn's patients. And they found in the ulcerative colitis patients, 51% of those patients had reported that they used cannabis in the last 6 months, and 12% of them were daily users. Very similar numbers in the Crohn's disease patients, slightly more in the daily users. And the patients, when asked why they were using cannabis, they reported that it helped with improve their appetite, decrease abdominal pain, and diarrhea, which is kind of supported by those physiologic studies that we talked about earlier in the presentation. And then they found that the patients that were the most likely to use cannabis were the ones that had the worst disease, the ones that had abdominal surgery, had used chronic analgesics, so like they've used opioids in the past, and these are the ones that were most likely to use, the group that was most likely to use cannabis. The Stats Canada estimates about 6% to 8 at most percent of Canadians back in 2018 were daily users. So this is about double the amount of the general population in this study. And then there's out of Israel, there's multiple studies coming from this group, and Naftali has published these really remarkable randomized control trials of showing, sort of trying to demonstrate the effect of THC in inflammatory bowel disease. So this is the first sort of groundbreaking study that he published, and it's quite a remarkable study. So he took 21 patients, and he took patients who had active Crohn's disease, where they have there's study. It's one of the ways to quantify Crohn's disease is using this Crohn's Disease Activity Index, or the CDAI score, and active inflammation is defined as above 200. So we took 21 patients that had a CDAI score above 200, and these were patients that did not respond to steroids, immunomodulators, which means like 6-MP or azathioprine, and biologics, which is the biologics that mostly used at that time was the TNF alpha agents. So he took those and he gave them a daily for 10 weeks cigarettes, so smoked, of cannabis, which had a set amount of THC, versus a cannabis where the THC was extracted. So to the patient, it smelled the same, looked the same, but one had THC, one didn't have THC. And they took this treatment for 10 weeks. He saw his results were very remarkable, and this was repeated in his later studies. And so in the people that had that were in the treatment arm, 10 out of 11 of them had what was defined as a clinical response. So it's a decrease in their CDI score of more than 100, versus only 4 out of 10 of them in the placebo group. Complete remission was seen in 5 out of 11 of them. So 10 out of 11 responded, 5 out of 11 went to complete remission, versus only 1 out of 10 in the placebo group. And 3 patients from the cannabis arm were completely weaned off of steroids, which is very remarkable. And the patients, like the treatment arm receiving the cannabis, reported improvement in appetite, their sleep, and no significant side effects were seen in the study. So I think, when talking about the positives, I think it's always important to talk about the negatives. And so it's the there definitely are some risks and adverse effects with using cannabis. There's most of these studies were done with recreational cannabis, so meaning these were definitely different than the medicinal cannabis that's used today. This is unregulated cannabis. This is cannabis that is mostly where there's a focus on THC rather than CBD or the other cannabinoids. And so there's so some people argue that these risks and adverse effects can't really be applied to medicinal cannabis, but medicinal cannabis hasn't been around long enough to really define those risks and adverse effects. So I think, using the best evidence at the time, I think it's appropriate to use these ones, even though they're focusing mostly on recreational cannabis. So one of the things that we see as gastroenterologists and emergency doctors see is something called cannabis hyperemesis syndrome. And this is where, despite cannabis helping with nausea and vomiting in the short term, if someone is taking a large amount, which is typically 5 grams or more a day, for a prolonged period of time, which means more than a year, they can actually paradoxically develop this cannabis hyperemesis syndrome, where they have refractory nausea and vomiting, which usually lasts. They can be very, very severe. They become dehydrated. It usually lasts for about 3 days. And there's very sort of odd and stereotypical behavior with this, where these patients are often quite obsessed with bathing, remaining in the shower throughout the entire day. And so it's quite a difficult period for these people. And the only way to treat this is to support them physiologically, give them IVs, try to help give anti-nausea, anti-vomiting medication, and wait it out. And after 3 days, it gets better. And then there definitely has to be some discussions over the cannabis use in these people. There is studies to show definitely that the smoked cannabis can cause chronic bronchitis. And there are studies to show an increased risk of lung cancer. However, when you do a subgroup analysis of this and take out the smokers, the tobacco smokers in these studies, there is no increased risk of cannabis and lung cancer. So it'd be interesting to see if there's some studies done where the tobacco smokers are excluded completely. There are some risks of it causes a large amount of cannabis can definitely cause decreased blood pressure, which can create some stress on the heart, especially in people who already have coronary artery disease. And so those are some things about it. The main sort of risk factors for me and for many doctors is the use in adolescents. Like the College of Family Physicians recommends not giving cannabis to prescribing cannabis to people less than 25 years old. In practice, however, because as many people with Crohn's and colitis and IBS and multiple conditions, mostly this gets applied at age 21. However, teenagers especially using cannabis, there's multiple studies to show that there's a decreased IQ in adulthood, and we're talking about daily large amount of cannabis use. Cannabis use once in a while in a teenager would not see these effects, but it is definitely dangerous on daily use. The evidence to show that the studies show poor school performance and dropout rates, increased risk for addiction, and there's some suggestion that it could be used as a daily drug. However, there are treatment centers that use cannabis as an exit drug. Definitely in young males, there is an association with cannabis use and progression towards schizophrenia and psychosis. The overall risk is low, so it's the schizophrenia accounts for about 1% of pretty much every population in the world. Daily cannabis use of a young male, it brings it up to 1.2%. On the studies I've looked at, but still, it's such a horrible disease that there's nothing. There should be as much vigilance taken to reduce the risk. However, when someone does have schizophrenia and psychosis, there are some studies to show that a beneficial effect of treatment on people doing well on to using cannabis for psychosis and symptoms. So, sort of a controversial topic at this time. So in conclusion, as like a CBC poll in 2018 showed that 7 out of 10 Canadians are in favor of use of medicinal cannabis. Many patients with Crohn's disease are already using cannabis and report that it's beneficial. There's definitely an interest, I can tell from my practice, in all generations to use more natural, putting that in quotes, because pharmaceutical companies argue that their stuff still comes from the earth and it's still not using natural components. But from a patient perspective, there's definitely an interest in natural medications, and there's kind of a distrust of big, their medical care being corrupted by big pharma. And this sort of really resonates in the cannabis counterculture of taking down the establishment. There is a significant interest by the government of Canada to expand the cannabis market and generate tax revenue, because they do tax medicinal cannabis unlike other medications. But however, there are limited studies to support cannabis as a first-line treatment, except for in some of the very slam dunk areas that we talked about, like palliative care, chemotherapy-induced nausea and vomiting, neuropathic pain, multiple sclerosis. Some studies in GI are very promising. However, they're limited by their small sample sizes. A large amount, like the data of showing complications, like I was saying, is a study of the recreational cannabis market. But there is definitely a harm reduction component to cannabis, especially when you're, considering it as an alternative to opioids, and it's often used as an exit drug for people with addiction. It's a relatively safe drug. It does have some adverse effects that we talked about, but as far as a mortality safety, there's no reported cases of cannabis-related overdose deaths, so meaning that the cannabis itself stops the person from living. There's definitely been car accidents that have been attributed to cannabis and mortality with that, but none from an overdose, unlike opioids. So that's the end of the presentation. I'll let Jeff take over from here.
Yeah, okay, thank you, Dr. Schneider. Before we actually dive into the Q&A session, I just wanted to remind the audience once more to register and sign up for the third and final part of the series. In that final segment, we'll be hearing from 3 different patients who suffer from various GI disorders and are using medical cannabis as a form of treatment. That webinar, once again, is being held on June 13th at 7 p.m. Eastern, and you can register going to cdhf.ca events. So we do have a lot of questions, and we'll start off with our first one. Will there be any study or research done in the area of gastroparesis and the use of cannabis?
Yeah, I do know that there are studies, and it's being actively studied. It's interesting in the sense that it's in my clinical experience, cannabis definitely does help people with gastroparesis. However, if you see from the physiologic studies, it does slow down the digestive tract, including the stomach, which is kind of the opposite of what you want to do in gastroparesis. So is there another mechanism that's going on, or is there there's likely more to that story. So that's why it's something that needs more study, and there are ongoing studies for that. So it'll be interesting in the coming months to see what comes out in that area. But it's something that I'm going to be actively looking for, and especially patients with gastroparesis. I'm sure that we'll also be looking for those studies too.
Okay. Next question. Do any of these studies, I'm just trying to rephrase these, but do any of these studies recognize whether the participating patients are current users of cannabis, or are they completely naive to cannabis? Has it made a difference?
Yeah, so talking about the inclusion-exclusion criteria on those studies, all of them, the person could not have used cannabis it depended on which study, but some of them was more than 12 months, some of them was more than 6 months. So it's an excellent question. So it could be definitely a confounding factor. So the authors of those studies, if you read the full text, which I did, excluded those patients. So if somebody was a regular user in the last 6 months, they were excluded from that study.
Okay. These studies seem to show that cannabis is great for symptom management. Have there been any studies promising findings on any cannabis properties that treat the condition itself instead of just managing symptoms?
Yeah, there are ongoing studies, but none that have been published yet. Other than looking, I think what you're asking is the typical, the different cannabinoids and which one is it. So obviously a very big interest in that area, especially when people are looking at making more synthetic cannabinoids and doing ones without THC. But the only study that has sort of really separated out was Dr. Nafati's study from Israel, where he really focused on the THC component. There's ongoing studies, but right now most of them are just the complete 102 cannabinoids included inside the treatment arm.
Okay. Medical cannabis has a lot of evidence for pain, which is a prime symptom of chronic GI disorders. Can it be used without the addictive attributes of, say, opioids that are used within those areas?
Absolutely. I mean, and that's why, from a harm reduction standpoint, in my practice, I would be looking at cannabis treatment before opioids, even before codeine. And I think it's totally appropriate, and I think it's justified to do that, especially with all the evidence in pain. Now, it is neuropathic pain rather than abdominal pain, which is which is a different category. But I think it is important. Cannabis is addictive, though. It is. There's plenty of evidence to show that it is addictive, but less addictive and much safer than opioids.
Okay. I've heard people mention something called microdosing. What is it, and would it be an effective way to treat my IBS pain? And I guess that's one of the big questions everybody has is how well controlled the dosing of medical cannabis is.
Yeah. So, I mean, all we were talking about in the recreational and medicinal cannabis webinar that we did 2 weeks ago. So all cannabis that is produced in Canada, it has to have, by Health Canada regulations, how much THC and how much CBD in milligrams. Now, those are only 2 cannabinoids out of 102 cannabinoids, so it's not necessarily that helpful, especially when you're getting, you're looking at CBN, CBC, CBG. There's many other potentially beneficial cannabinoids. And so getting the right dose and starting off is very difficult. I hate to sound redundant because I've heard so many cannabis talks, but every single talk I've listened to, they always talk about this go low, go slow way to do it. And that's sort of the only way. It's just like opioids in the sense that, or alcohol even, that we all react to those substances differently. And it really becomes an individual preference. And so the safest way to do it is to start on a very low dose. Now, that might be annoying because you'll take a low dose, you won't feel anything, it won't make any difference, and you'll suffer, and it'll be a complete waste of time. However, I think that is superior to other people that I know who, taken a higher dose and they felt really not good. They felt they became slightly hypotensive, they felt dizzy, they really didn't like the feeling that they experienced, and then they had to, and then they decided not to pursue the cannabis treatment because it really was unpleasant for them. And so the only way if you're getting a medicinal cannabis prescription, is to order the small segments of dosing that you can, It's good to do one that has I would suggest a THC to CBD ratio of 1-to-1, because the CBD does counteract the psychoactive effects of THC, and so that's the way that those side effects of THC wouldn't be present. So I do a 1-to-1 ratio, the smallest microdoses that you can, and just start really low and just ramp up until you're getting the desired effect, which will take at least a week before you'll get the right dose, even longer for most people.
Okay, so I think you've actually kind of answered a couple of the questions. One of the questions that many people do not want to experience the hallucinogenic effects. Out of all of these studies, were any of the cannabis products used the CBD form without the THC? Does CBD have the same ability to manage pain and nausea without THC?
Mm-hmm. Well, these are sort of basic science studies, so they're not clinical studies. So they're saying lower on that hierarchy. They're ones that we talked about, but there are studies out there that they do show a synergy between THC and CBD. So if you and there are CBD only. So CBD is like the predominant. Like, so if you take the THC out, the hallucinogenic effects are almost all completely gone. So you have this, a CBD only, oil or pill, and those you will not have any like hallucinogenic effects. People will work or drive, with no impairment within a CBD only component. And the problem with CBD only is that it's less strong than cannabis oil that has THC in it. And so because they do work synergistically together. So the best would be to find that good ratio for somebody. And the best would be if you're apprehensive about the psychoactive effect, is to start with a CBD only component. And if you're not, if that's sufficient, if the CBD only is enough to control the pain, or the diarrhea or the nausea, then fantastic. Yeah, I think that's an excellent option. However, if it's not enough, you may want to go slightly up on the THC ratio, still trying to keep as predominant as CBD, and that the THC will help CBD work, but the fact that it's a large CBD ratio, it affects the psychoactive effects of THC. So kind of a circle discussion that I'm sort of presenting, but that's the practical uses of playing with those ratios. So if the pain's not well controlled, you may need to add some THC in. But as long as there's a large component of CBD, the psychoactive effects of THC will be largely minimized, if not completely negated.
Okay. Well, that's the last question that we've got. So, Dr. Schneider, I want to thank you very much for taking part again and doing the second in our series. And we look forward to hearing from you again next week, or 2 weeks from now, on June the 13th. And I want to thank everyone for attending as well. Thank you.
Thank you. Good night.